All right, here we are. Today we're going to be talking about neuropharmacology. So, in this section, for lesson 11, we're going to break it up into two parts, okay? So, for 11.1, we're going to be talking about something called pharmacokinetics. And we really need to understand the basics of what pharmacology is and what's involved with pharmacology to talk specifically about neuropharmacology. So, what do these terms mean? Well, pharmacology, in a basic sense, is how chemical agents, so how drugs, are going to affect biological systems. So, drugs can come in various forms. We can be talking about really anything exogenous that we put into our body. So, it could be a drug from a pharmacy. It could be something that you take by prescription. It could be over the counter. It could be some sort of natural extract that's taken directly from the environment, right? So when we talk about pharmacology, we're going to be talking about several different aspects of it. Of course, the biological effect is a key element of this because essentially we're going to be evaluating how different types of drugs are used in treatment of different types of disorders. We're going to be talking about drugs of abuse. So the effects on the biology is important. We're also going to be talking about mechanisms of action, and that is to say precisely how a drug ultimately exerts its effects. So we talked about receptor types. Really, mechanisms of action is going to be what type of receptor is acted upon, so what the drug binds to, and how how the cellular function is altered based on receptor activation. And therapeutic, which really involves our ability to improve some sort of outcome. Okay, so that's therapeutics. There's going to be a difference. Just because we take a drug doesn't necessarily mean we're going to have a therapeutic effect. We have to have enough of the drug binding to the receptors in order to actually produce an effect on the biological system. And toxicology, which refers to the adverse effects of a drug or a drug's toxicity. So, how harmful the drug could actually be. So, these are basic tenets of pharmacology. Now, when we talk about neuropharmacology, we're really just getting a little bit more specific because neuroscience deals with the nervous system. So, neuropharmacology is essentially a subdivision of how drugs affect the nervous system, right? So it could be central nervous, peripheral nervous system, and really both. Because if we take anything systemically, so in other words, we take something that's going to go into the bloodstream and be pumped throughout the entire body, it's probably going to exert effects on both levels, both central and peripheral. So the first thing we're going to do is we're going to talk about kinetics. And in pharmacology, we have what we call pharmacokinetics. Now, pharmacokinetics deals with everything that happens once you put the drug in, okay? So it involves introduction of the drug, okay, and the drug passing throughout the body and eventually being eliminated from the body. All right. Now, when we talk about pharmacokinetics, we're not really talking about exactly how the drug acts or what biological effect it produces. We're talking about how much of it is there. So once we take the drug, it has to get absorbed into the body, and it has to get distributed throughout the body, and it has to reach its site. So the pharmacokinetics are how quickly and how this actually occurs. And so we're gonna see a little bit of that. And there are four major parts of this. We have absorption, distribution, metabolism, and elimination. Now, this is what we call ADME, and ADME is a very central part of pharmacokinetics. So again, the kinetics here, we're not really talking about the overall effect that's produced by the drug, right? So we're not talking about, for example, ability to bring down fever. We're actually talking about how much of the drug gets into the circulation once we take it. And there's things that affect this. All right. Now that's distinct from what we call pharmacodynamics. Pharmacodynamics, okay, really is the interaction of the drug with its receptor and the activation of the pathway that receptor controls and the outcome that's produced. So pharmacodynamic, I put the example here, okay, you might have norepinephrine, right? That's one of our adrenergic. It's going to bind to a beta-1 adrenergic receptor, which ultimately is going to increase heart rate, okay, or increase the number of beats per minute that the heart is pumping blood throughout the body. That is a pharmacodynamic effect. Now, how much, if we have a drug like a beta agonist, okay, we can actually mimic this effect by taking this drug, and this beta agonist, and we'll talk about what that means later, is going to bind to this beta 1 adrenergic receptor and cause the same effect. Okay. Now, if we're talking about how much of our beta agonist actually gets into the bloodstream and how much of it ends up in the target tissue, that is a pharmacokinetic discussion. Right? So, think of it this way. We take a drug, and it could be anything. Let's say it's an aspirin. What we really need to kind of remember and think about is once you take any kind of drug, it's going to get absorbed, right? So we have to get this absorbed into the body first before it can have any kind of effect. So we start to ask questions like, how much of it is actually going to get into the blood? Because in order for a drug to produce an effect, it has to be present at certain levels. So one of the challenges is always making sure that we can get what we call therapeutic levels. That means we get enough of the drug in the system to actually produce an effect, right? Now getting that into the system is the kinetic aspect of it. Producing the effect is the dynamic aspect, right? So of course it has to get distributed throughout the body. When this happens, there's going to be enzymes that are going to be trying to break it down. It's going to be sticking to things. We'll see that in a minute. Okay, how much of it actually gets to where it's supposed to be? That's going to be another part of it. So we take the drug, and let's say I'm taking an aspirin because I have a headache. Well, I'm going to swallow the aspirin. It's going to go into my stomach first, but ultimately I need to have relief in my head because I have a headache. So how does that transformation actually happen? How do we end up going from taking this pill and then have it actually get to the site that it needs to go to? Right? Because we can reasonably assume that my headache is not originating from my stomach. So in order for this to be effective, it needs to get distributed to all the tissues, and we call the target tissue the one that we're actually trying to get to. All right. And then after that happens, we can determine whether or not we've got an effect. Okay, so did it work? And do we have additional effects that we don't like, which we call side effects? Okay, and that has to do with a drug either binding to areas that we don't necessarily want it to bind to, and sometimes that causes problems, or having too much of it that we can't break it down, and sometimes that causes some kind of toxicity in the body. All right. So, what do each one of these really mean? When we think about absorption, we're talking precisely about entering the circulation, blood flow. Okay? So, absorption, there's some key things we think about. The first one is solubility of a compound. So, we have a drug, how soluble is it? Well, the reason why this matters, okay, is because the type of drug that we have, how much of it is in either the ionized or non-ionized form is going to depend on where it goes and how it absorbs, okay? So ionized substances tend to be water soluble, right? And you probably remember this from chemistry. You have to tap into your old chem now, bringing that back up to the forefront. And if it's non-ionized, okay, so this tends to be things that are more lipid soluble. Now, the reason we're going to see why this matters in a minute, but there's different compartments in your body. Some are more lipid based and some are not. So, absorption of a drug is going to depend a lot on this, right? If we're going to give a patch, for example, a transdermal patch, it's going to have to absorb through your skin, right? Through a layer of fat and through some, well, really, this fat is the key part, right? So it's got to be fairly lipid soluble if it's going to be able to absorb through that. Okay, so this is a key determination. And ultimately, what we're concerned with is the bioavailability of the compound. Now, bioavailability basically is a measure of how much of the drug is going to get into the bloodstream. Okay, and really, in the end, we don't even really just care about the bloodstream, but it's how much of it's actually going to get to the target tissue. Okay, so sometimes you hear people talk about bioavailability, and they're talking about absorption into the systemic circulation. So that's what we call basically, the bloodstream, all the vessels throughout your body. But really, we then need it to actually get into the target tissue as well. Now, in neuroscience, when we're talking about a central nervous system agent, for example, we want to take a drug to combat depression, it's going to have to act at the level of the brain. So we have an added barrier with the blood-brain barrier, that makes it a little bit more challenging, okay? Because we need compounds that are more lipid soluble, but we're going to see that later. All right. And ultimately, when we talk about bioavailability, we're talking about two things. And it's not always this simple, but for us, absorption, okay, so how well we can get it to absorb, but also the distribution. Okay, this is the next part we're going to talk about. So consider this example. We have a drug. We have, let's say, 10 milligrams. It doesn't matter. It could be anything. We'll say 10 milligrams of it. Now, this is an example, okay, of how much of a particular drug will end up in different places in the body. Okay, so here we say we have 10% of unbound drug. Okay, so 1 milligram out of this 10 actually makes it into the blood, into the plasma, okay? Now, out of that 10% of our original amount, 0.2 milligrams or 2% is actually going to end up in the target tissue, okay? So we started out with 10 milligrams of drug that we took, okay? And out of this 10 milligrams, really only 0.2 milligrams ends up in the target tissue. So what happens to the rest of it? All right. Well, the distribution and the solubility of the compound, right, are going to affect this because some of it's going to get absorbed into different tissues, okay, other than the one that we want. Okay, so in this case, we actually have 5 milligrams of it goes there. Some of it is going to get stuck into fat deposits. So again, depending on how lipid soluble your drug is, you might have some of it getting taken up into fatty tissues, okay? And a lot of it's going to get bound to plasma proteins. Now, what this means is that when you take a drug and it goes into the blood, there's proteins floating around in your blood, right? There's all types of different things. And drugs will bind to some of these plasma proteins. And when they bind to the plasma protein, we're essentially eliminating them from possibly binding to a receptor, right? Because if they're already bound to something else, then they can't act, okay? It's like we're essentially removing them from the equation, right? So the distribution, like we said, moves through the body, right? We're talking about how much of it's going to get to the target tissues. In terms of this plasma protein binding, this shows you quite nicely. Here we have free drug. So let's assume that we have some absorbed into the body. Now it's floating around. But we also have these plasma proteins, okay? And some of these plasma proteins are binding this drug, okay? So these are the blue guys are the plasma proteins, and the green ones are the drug. So when these are bound, the drug is not free to act on its receptor, okay? So these guys are going to get taken out, and a lot of times they actually get excreted, okay, through normal processes. Another thing that is a key for affecting distribution, obviously, is the circulation, right? So we have to have really good blood circulation, and we have to have the blood flow working very well to be able to distribute drug throughout the body. So anytime you're dealing with a situation where somebody maybe has cardiovascular disease, where there's some sort, and there's lots of different types of cardiovascular disease and different ways you can get it. Like you might have a plaque in an artery that's obstructing blood flow, right? So you've heard about you eat too much fatty foods, maybe too many of those awesome ribeye steaks that I love or something like that, right? And so over time you get plaques that develop in your arteries, so your blood vessels narrow, okay? So maybe this is only half the diameter that it used to be because there's plaque stuck in here, so less blood can flow, so that's going to affect your distribution, right? And there's other types as well. The other part of this too is whether or not, again, we're trying to cross and diffuse through normal capillaries or whether we're trying to get across the blood-brain barrier. So this is what I alluded to before, okay? Now, typical blood vessels actually have spaces in them that are that allow for hydrophilic substances, so things that like water, polar stuff, to diffuse into, okay? But the blood-brain barrier has an added challenge because it's very, very difficult to get things in here, okay, that are not very lipid soluble, okay? So as our guy is telling us here, he's basically blocking this blood-brain barrier. So if we have a drug that we need to get into the brain, here, hey, we want in, and this guy is saying, nope, sorry, you've got too many charges, okay, or you're too big, or you're not hydrophobic enough, you're not lipid soluble enough, okay? So this barrier is a very specialized one that keeps things out based on this basis. So again, all right, the ionization of the drug, okay, how much of it is in the ionized or non-ionized form is going to is going to dictate how much of it actually gets into the brain, right? And also how lipid soluble it is and all those things. So the chemistry is really important. It's complicated. So here, one of the reasons why treating brain injuries and different types of brain diseases is difficult is because of this blood-brain barrier. It really does restrict things. So I just kind of wanted to sort of highlight some methods that are always being researched to try to improve the way that we can get drugs into the brain. So there's different thoughts of what might be the best way to do this. There are some approaches that actually target increasing the amount of permeability, so we can give an agent that's actually going to make the blood-brain barrier more permeable temporarily so our drug can get in. Of course, that's a double-edged sword, right? Because if we're making it more permeable, that means other stuff can get in too. Maybe toxins, maybe things that we don't want to get into the brain, aside from our drug. So that's tricky as well. Or temporary disruption is sort of the same thing. Or these other methods where we can actually directly deliver things into there. But again, this is not really something that you need to focus on remembering. It's just kind of brings it full circle as to why it's so difficult to treat mal adaptions in the brain and different types of problems that we might have, whether it's after injury or it's due to something like a depression or schizophrenia or any other type of disease that's primarily rooted in brain function, right? So metabolism, what does that mean? Well, metabolism are chemical reactions. Really here we're talking about breaking things down, okay? So drugs need to be broken down into simpler forms that we can then either recycle or essentially excrete out of the body to remove. We call this biotransformation, okay? So what happens with the metabolism is that we have enzymes responsible for this. This diagram here essentially just shows you that there's a couple different ways that drugs are metabolized. There's what we call the phase 1 and the phase 2 pathway. Now you don't need to know all the details of this, but it's good to kind of point out and see how this works. So the key point here is that a major site of drug metabolism is actually the liver. So in the liver, we have lots of enzymes, and one of these major class of drug metabolizing enzymes are called cytochrome P450 enzymes. We call these CYPs. Okay, there's lots of different CYPs that are involved in breaking down different drugs, and they're specific. So one type of CYP may break down drug A but not drug B, etc. Okay, and what you can see here is that we give the drug, and we can break this down into what we call metabolites. So the metabolites are the simpler chemicals that are broken down from the initial drug, right? And then we have a couple different pathways that this can go through. Essentially, we're talking about redox reactions, okay? So reduction and oxidation of the chemicals themselves. We also have these things called glucuronidation. This is a major type of method of breaking down drugs. You don't really need to know the details of that. But the point here is that once this occurs, okay, we actually end up with either polar or non-polar metabolites, okay, and they could be eliminated different ways, right? So we can either have renal excretion, which is your kidneys essentially, and then coming out through your urine, or you can have the other method where it comes out through the feces. But here we can see that we actually have so metabolism out of the gut here, and then we have direct absorption through this portal vein that goes directly to your liver. All right, and this is something that we call first pass metabolism. We're going to talk about this a little bit more. But basically, so we're breaking things down, we're metabolizing the drugs, all right? And then finally, elimination, how do we get rid of it, right? So for the most part, drugs are excreted through the kidneys, all right? There are exceptions to this. So here you can see the kidney is actually going to excrete through the ureter into the bladder, and it's going to come out through the urine, right? So this is the majority of drug clearance happens this way. But sometimes we can actually have elimination through the skin and lungs and some glandular sort of things. Everybody's familiar with this. So this is a breathalyzer. This is an individual who's blowing into a breathalyzer. So the metabolites of alcohol, okay, are actually excreted through in part through the skin, through the lungs as well. So this is the reason why we're able to actually detect how how much alcohol somebody has consumed is based on the amount of alcohol metabolites that are actually being excreted through this method. All right, makes sense? All right. So, what is the most important thing about bioavailability? When we talk about pharmacokinetics, all of these things really boil down to the major point, which is bioavailability. How much of the drug gets into the circulation? How much of the drug gets to the target tissue? Okay? Is it going to the place we need it to get to? That is the key. Okay? So, factors affecting the size of the drug, okay, the charge of the drug. Now, you remember from basic biology the way that membranes work, right? In order to get charged particles across a membrane, what do we need? We need specialized types of transporters, right? The size of the drug as well. It's hard for big things to get through, okay? Now, this is particularly important when we're trying to get something across the blood-brain barrier because the regulation there is even tighter, okay, to get things through that vascular layer into the brain tissue, what we call the parenchyma. But that's actually just another word, fancy word way of saying inside the brain. Okay, so the charge and the size are super important. The ionization state. Now, this is something that's measured. It's called the pK. Okay, sometimes you'll hear pKa. Sometimes people just call it pK. This is an ionization constant. So we talked about this already, and we're not. Don't worry, you're not gonna have to do any math with this or anything like that. But this is essentially just to show you that drugs can be acidic or they can be basic, right? And we know that acids and bases can be strong or weak, okay? So most drugs are weak acids or weak bases, and this means that they're going to dissociate to some degree, right? So a weak acid or base doesn't dissociate completely, it only dissociates partially. So at any given point, if you have, let's say, a weak acid, for example, you're going to have a large proportion of it that's in the acid form and some of it that's been ionized, okay? Well, the reason why this matters is because the pK tells us the pH at which 50% of the drug is ionized, okay? Now, if we know the pK, we have some idea of how soluble it's going to be in different compartments, okay? So, for example, the stomach has a pH of about 3.4 to 4 or something in that neighborhood. The blood has a pH of about 7.4, okay? So, if we know how ionizable a particular drug is, it's going to give us some idea of how well it can absorb into different compartments of the body, right? So why does that matter? Well, if we have a drug, okay, that we're going to give orally in a pill form, and it's going to go into the stomach, and the pH is about 3.4, we'd better be sure that we're going to have a drug that's going to be able to actually survive and be absorbed through that cavity into the bloodstream, all right? Similarly, we want something that's going to be able to be carried through here. So these are important considerations about bioavailability. What is the actual chemical structure of the drug? That's incredibly important, right, for similar sorts of reasons, but also polarity, okay? We talked about the acidity already and whether or not it's basic or acidic, but if it's polar or nonpolar, and the route of administration is also very, very important. And the routes of administration usually are selected based upon the chemical properties of the drug, okay? So what the pK of the drug is, right? And how polar the drug is, how lipophilic it is, right? So how lipid soluble it is versus how water soluble it is. That usually is going to affect what the route of administration is. Now, what the heck does this mean? What is a route of administration? Route of administration is just how you take it, how the drug is given. Okay, so there's lots of different routes of administration, and one of the ones that we're going to spend some time talking about is the oral route because it kind of brings home all these different points. And the final thing, of course, is your overall health. That's going to be affected by bioavailability. And this we talked about when I brought up the idea of cardiovascular disease, right? So your overall the overall activity of your body, okay, if it's good and your body's doing the things that it's supposed to do, you're going to have better luck having drugs absorbed and distributed throughout your body, right? It just sort of makes sense. Okay, so what is routes of administration? Different ways you can take a drug. Okay, so we have the oral route, which we call PO. Okay, intramuscular, subcutaneous. All right, so basically we can take a drug in pill form. This is oral. This means we swallow it. It's going to fall into the stomach and it's going to get absorbed into the intestines. Right. We can take intramuscular, which usually means that it's going to be injected into a muscle where it's going to absorb into the body a little bit slower. Okay, subcutaneous is also another way. We can inject it just below the skin into the compartment below, and that's going to allow a slower sort of absorption. Intravenous is a very quick route. So this is one where we're going to inject it directly into the circulation, okay, directly into the venous circulation, so the blood, right? Intranasal, so that's basically through the nose. Sublingual and intrathecal are a couple of less common methods, okay, and then rectal. But basically the idea here is that these different routes of administration, they're going to affect absorption differently, all right? So if we can take a look, here you can see the muscle. We have a heart pumping, okay, back and forth to the brain, back and forth to the muscles. We have some fatty tissues here. Here we have our kidneys, okay. So this is the key area that's going to be involved in the excretion, okay. So if we inject something intravenously, it's going to go right into the bloodstream, okay, and it's going to go directly through all these places and get distributed pretty rapidly, versus oral ingestion of a drug. So if we take it orally, it's going to go down into the stomach, okay? And what happens is it has to get absorbed into the intestines. And before it ever makes it to the circulation, it's going to go directly to the liver. So there's actually a portal vein, okay, that's going to go from your intestines after you swallow something and it gets digested, absorbed into your small intestines. It's going to go directly into this vein and get brought right to the liver. Now remember, the liver is a major site of drug metabolism, okay? So things that are taken orally tend to get very heavily metabolized in the liver before they ever actually make it to the circulation. Now this is what we call first pass metabolism, because first pass means that it is first passed through the liver, okay? So think of it that way. First pass through the liver before it actually ever makes it into your bloodstream. All right. This is just sort of another example of the different ways that this happens. And here you can see that if you actually took a drug orally, all right, it would start off here in your digestive tract. It would then go through this portal vein to your liver, and a bunch of it would get metabolized by all these liver enzymes before it actually ever makes it into your circulation. Okay. Whereas if we injected something intravenously, okay, IV injection, you're putting it right into the circulation, okay, so it can then go and get distributed into all these places, all right? So sometimes we have a drug, we can actually apply it directly to a spot if it's topical, right? So you might have had some sort of antifungal agent that you get from the store. If you have some, like ringworm or something like that, you can put it right on the affected area and it works great. Sometimes we can inject it into the target tissue. Like, for example, somebody who has arthritis, they might have injections in their knee, right? So you can put it right in. But most of the time, okay, when we talk about drugs, and certainly what we're going to be talking about in this course, we can't put it directly in the tissue, especially if we're talking about the brain, right? It's very dangerous to actually inject something directly into somebody's brain. We don't really do that anymore, okay? Unless they're in the OR and they're, having a very difficult time and it's an emergency procedure, okay? Normally we don't do that. So we need to get it into the circulation so it can get pumped into the brain, okay? And so again, here we talk about this idea of first pass metabolism means it's first passed through the liver, okay? And so because of this, it's going to reduce the bioavailability because a lot of it's going to get broken down by the liver before it actually ever gets into the circulation. Okay, but most drugs are taken orally because we don't like to get injected, right? And we don't like to. The other routes of administration don't tend to be as comfortable or as tolerated. All right. So what we do here, okay, is because of this first pass effect. Here again, you can see that there's oral. Okay, so this goes into the stomach. into the intestines, into the portal circulation, okay, and the liver digests it before it ever gets into the systemic. Whereas if we had a drug and we were to do an IV injection, we would get it directly here before any of it gets metabolized, okay? So these things affect bioavailability. You might have less bioavailability with an oral agent versus something that you inject IV, okay? And one of the ways, or actually the major way that we measure bioavailability in pharmacology is through what we call plasma concentration, okay? So this is the amount that actually makes it into the blood plasma. Remember, the plasma is just a fraction of the blood. It's part of your blood. So plasma concentration, okay? And it's measured by what we call area under the curve. So here you can see plasma concentration is plotted on the left on the y-axis. It's in milligrams per liter. So this is a concentration of the drug. And then we have time. So this actually shows you how much of the drug makes it into the bloodstream over time, okay? So here you could actually track this and we can see how it's being absorbed. Here we've reached the maximum amount that can be absorbed into the body, okay? And then as it starts to go down, we can see that the concentration goes down because why? Yes, that's exactly right. It's being metabolized and eliminated. Okay, so it's being metabolized and eliminated from the body. By the way, some drug actually gets eliminated without being metabolized. And it just depends on what type of drug it is, all right? Now, to alleviate this problem of first pass metabolism and reducing the bioavailability, because remember, we want to have more of it. We got to have enough drug to actually produce a therapeutic effect, right? So a lot of drugs are given as prodrugs, okay? And what a prodrug is, it's a drug that's formulated or prepared in a way, okay, so that it's actually not initially present in the active form. Okay, so the compound is modified so that it needs to be metabolized into its actually active form once it's absorbed into the body. Okay, so what this does is it actually can reduce the amount of active drug that's actually degraded before it actually ends up in the systemic circulation. Okay, so for example, you might take a pill that's in a prodrug form and it's going to sit in your stomach for about 30 minutes before it actually gets absorbed. Now there's all these enzymes in your stomach that are degrading proteins and they're breaking down molecules and things like that. So you might want to give this drug sort of in a different form so that it can survive past the stage of all that metabolism, get into the bloodstream, and then be metabolized into the actual active form. Because if you gave it in the active form in the beginning, it might all get degraded before it actually ever reaches the systemic circulation. Okay, so this is a pretty cool little technique that people use to try to do that. The alternatives, again, are to use different routes of administration. Okay, so if we look at this curve on the right, or this graph on the right rather, we can see these are plasma concentrations. Now this was a study that was performed with different concentrations of cocaine, okay, that were administered, and they were measuring the amount that was in the plasma. So they were doing area under the curve plasma concentrations here. Again, what they do is they basically sample a little bit of blood at different time points to measure the amount of drug, and then you can plot a curve for it. Okay, so here we can see that the intravenous route produces the best bioavailability, right? We have the fastest maximal concentration here. And that makes sense, right? Because we're injecting it directly into the circulation. So we're going to expect to see more of it in the blood much quicker, okay? Versus this blue one here is an oral route. And we can see here at about 30, we don't really have any plasma concentration until a little over about 30 minutes here. And again, like I said before, it's going to sit in your stomach, in your digestive tract for about 30 to 45 minutes before it actually ever enters the bloodstream. Okay, so that's what this graph shows here. So that's why we don't start to get concentrations yet, and then ultimately we end up with not as much. Okay, and part of this is probably because it's metabolized beforehand. And if we were to smoke this cocaine here, we can see that it's actually goes into the bloodstream very rapidly. Well, this kind of makes sense too, because if we inhale something through the lungs, remember it's that gas exchange site, it's going to go directly into the circulation. Okay, so we don't have any first pass metabolism. All right, and the same thing here with intranasal. So these are all quicker routes. All right. So I hope you enjoyed this. This is the first part. The second part, we're going to be talking about pharmacodynamics and how drugs actually affect receptors and do all of the wonderful things that they do. The biological effects of the drugs. So enjoy this quiz, see how you do, and I will see you next time.